Yeah, then good morning from my side. My name is Marina Schmidt. I'm a neuroscience master student. I'm writing my master thesis here right now. But I've already been in the institute for quite long, 2.5 years now. And one project I started last year was the rapid generation of diagnostic parameter maps from Sparse Hadamard-Encoded ASL using machine learning. A lot of words, but we're going to step by step through it and then you'll understand it. We are going to hear in a second why perfusion measurement is super important in the clinics. And I'm going to show you how we can do perfusion measurement in MRI. And there are different methods, but one method we are working on in the institute is so-called arterial spin labeling. And compared to the clinical standard, it's non-invasive and it's contrast agent free, which is super nice. And how does this work? It's using the blood water itself as an endogenous contrast agent. So we know if we put a subject into strong magnetic field, the magnetization of the hydrogen nuclei will align with the magnetic field. You can see this like by the two arrows pointing into the direction of B0 here. And so normally the blood will flow into the brain and the magnetization from it will be aligned with the strong magnetic field. But now we set a labeling plane stream upwards to, in this case, the brain, but it also works in different organs. And now the blood that comes into this labeling plane, the blood water will be magnetically labeled by inverting this magnetization. And then the magnetization or the blood will flow into this brain magnetically labeled. And if we then stop the labeling, the blood that's coming afterwards will be aligned normally with the magnetic field again. And by magnetically labeling the blood, we can exactly trace down the way that the blood takes into the brain capillary system and in the end, the tissue. And then we can acquire an image. And the thing is that the perfusion signal then in this image only is about 2% of the overall MR image, which is not that much. So we can not just see the perfusion signal in the image. So what we do is we take a difference image because we assume that the static tissue in an image where we label the blood is the same as in an image where we don't label anything. So we take a control image where we don't label anything. We take a label image, we subtract these two, and the difference that persists is the perfusion signal, and then we get a perfusion-weighted image. And on this perfusion-weighted image, we can then do some math. We can quantify it, and we can get to some clinical parameters that are important for different kinds of diseases. And two of them are the cerebral blood flow and the arterial transit time. CBF does tell us how many milliliters of blood travel through 100 grams of tissue per minute. And ATT does tell us how fast the labeled blood travels from the labeling plane into our readout voxel. And as I told you, the nice thing about ASL is that it's non-invasive and contrast agent-free, which is always an advantage. But the main challenge in ASL is the SNR. And so one method to boost the SNR in ASL is using time-encoded arterial spin labeling. What do we do here? Instead of having one long labeling bolus, we divide it in a train of sub-boli. And now these sub-boli don't always have a label condition, but also sometimes they do have a control condition. And now we just acquire one image, but each of these sub-boli here, let me take on the laser pointer, they have an individual time until the image is acquired. So when we label here, this bolus will have traveled further into the brain than the last one. And the image we have in the end that we acquire does have information about label and control in it. And because each of these sub-boli had a different time until the image is acquired, the information in this image is time encoded. But to get to the perfusion signal at each time point, we somehow need to decode this image again. We have to know at which time point where the perfusion signal is. And one method to do this is by using a Hadamard matrix. Hadamard matrix is a matrix that just has the entries +1 and -1. And one row of a matrix is one image acquisition. So in this case, an 8 × 8 matrix does give us 8 of these time-encoded images. And what we do is, whenever there's a +1 in this matrix, we send a control pulse. And whenever there's a -1 in this matrix, we send a labeling pulse. So an example, the second row, we would send 4 control pulses, we would send 4 labeling pulses, give the blood a chance to travel into the brain, and then acquire our image. And we do the same with like different scheme for every of these time-encoded images. And now we have this 8 time-encoded images, and we somehow need to get to our perfusion signal. And I'm going to show you this on the example of the last time point, because what we do is we take all of these acquired encoded images and we add them all up, but with respect to the sign of the entry in the matrix column respective to the time point. So here we have the last time point, meaning we are taking the last column of this matrix and we're adding all of these images, but with respect to the sign. So we take the first, we subtract the second, we add the third, we subtract the fourth, and so on. You get the concept. And we do this for every other column as well. And then we get to this perfusion-weighted image shown down here. And the nice thing with this method is that we have higher SNR, because in one image we have more than one labeling and control. We have more signal. But the biggest challenge with this Hadamard, and now we come in to my topic, is that it's super sensitive to motion. Because if only in one of these time-encoded images there is like a little movement and we have an artifact in there due to this, as we add all our encoded images, in every of the perfusion-weighted image there will be this error, because we add all of them. So just a little error in one image will give us an error in every image, the perfusion-weighted image, and also then after quantification in CBF and ATT. And furthermore, this quantification process with standard tools takes quite long. You need 30 to 40 minutes to get from your perfusion signal to the CBF and ATT maps. So we thought what is needed is a rapid generation of these diagnostic parameter maps from sparse Hadamard-encoded ASL, meaning leaving out some of the encoding images, but still getting full reliable parameter maps. And I tried this using machine learning. For this, I implemented a conditional GAN network. And in a cGAN, it always consists of a generator, which generates images, and a discriminator, which discriminates images. And how does this work? So the generator gets an input image. In this case, it's the encoded image. And it generates an image of another modality. In this case, for example, CBF. And then the discriminator gets either a generated image, or it gets a ground truth image, and it has to decide whether the image it got was generated or ground truth. And this is often referred to as a two-player min-max game, because you can imagine if the generator is really working poorly and generating images that don't look at all like the ground truth image, the discriminator has an easy job to tell that one is generated. So the better the generator gets, the harder the discriminator has, the harder the discriminator's job is, and so on. And this is how the network learns to generate quite good images. That's the theory part. If you have more questions about how I learned on which graphic or GPU I learned, just come to me. But I'm going to show you some results now because time is running. So first I wanted to see, does the cGAN at all work for this kind of job? Does it generate maps that look like true quantified maps? So what you can see here is I included all encoding steps. And on the left side, you can see the ground truth CBF map, and on the right side, you can see the generated one. And you can see that the structure is pretty good land, and also the CBF estimation in the regions is pretty similar in both images. I also used evaluation metrics for the evaluation of these maps, and also there was always a strong correlation between the ground truth image and the generated one. Now, if we come to the sparse part about it, if I leave out half of the encoding steps, so I'm losing half of the information from my data, that's how a generated map then looks compared to the ground truth one. And yes, we can see noise is increased and also some details get lost. But again, if you think half of the information is lost, this is still a pretty good resample of the ground truth. As in reality, if you have movement in half of your data, you would just lose your data set because quantification would not give you a reliable map. yeah, to wrap this up, I can say if all encoding steps are included, comparable maps can definitely be generated. And also it's a massive time improvement. I told you before, quantification takes about 30 to 40 minutes. Here I need 3 seconds. And this is also the main advantage, even if the map is not as good, if we lose half of the information as it would be if we have all the information, we can get a super quick glance on how CBF could look like. And we could also use this maybe if we, in the time where we wait to scan the patient again, we could still have a glimpse of what CBF could look like. And yeah, even if we lose half of the information, still information is quite good. There is still some instability in the results, but also my data set was quite small. I only had 26 subjects, so I trained on 20, which is definitely not much. But I'm working with people now who have a larger data set. And also I just trained on healthy subjects. So at this point, I'm not sure if there would be alteration in perfusion, my network could provide us with this information, or if it would just make everybody healthy, so to say. But also in the larger data set now I'm working on, there are older people included which have alteration in perfusion. And that's it. I'm already coming to the end. If you have any questions, let me know.
Actually, I was wondering about if you have some kind of quantitative metrics for the regeneration, like you said the generation is like below from 30 minutes to 3 seconds, but what was loss of the accuracy?
Again, sorry?
What was the loss of the reconstruction? What is the error? Like you get it from, like it's pretty good to get from 30 minutes to 3 seconds, but what was the effect on the other side?
I cannot tell you the loss. I don't have these numbers with me, but I do have some, like I put some metrics in the end, if that was your question.
Yes. Yes.
So that's for CBF if all steps are included. And you can see that like Pearson and structure similarity index are about 0.9 all the time, and also root mean squared error is pretty low.
Your results are so
Yes. Thank you. Are there any more questions? Then I could have talked slower if there were no questions. I was rushing through to give you time to have questions. Yeah.
Yeah. Is there any difference between the ground image, the spatial resolution of the ground image and the generated one?
No.
And because, like, or in the contrast, I mean.
Can you repeat the question?
Yeah, sure. So there was the question if there's a difference in spatial resolution in the images or a difference in contrast. And so no, the spatial resolution is the same. And if there would be a change in contrast, that would mean that the CBF or perfusion estimation would be different as well. So the ultimate goal is that there is no change in contrast, because contrast does tell us how strong perfusion is in the region. So spatial resolution definitely the same. Contrast with this metrics not 100% the same, yes, but pretty the same.
I couldn't catch the part. What tool you use to make the pipeline?
Mm-hmm. So the question was showing the pipeline again. So this one?
Yes.
Exactly. So I used a conditional GAN, that's the name of the network, and that's always this generator and discriminator thing. And for input, I used the encoded images. So if I go back to this slice, so I used these images directly as an input, and the output was then the parameter maps, so CBF and ATT. So I also got rid of this decoding step, which is normally not really time consuming, but still it's not needed because I can directly train on these images. And I used, so for loss, I used the BCE combined with a weighted L1 loss. Exactly.
Thank you.
Yes?
What is the loss function that you use?
BCE and L1 combined. Because BCE, that sometimes does give you images that it thinks looks pretty much like the ground truth, but to be sure that also resolution and contrast is the same, just a question we had, I also used the weighted L1 loss for it.
But I'm not sure about the hallucination. This is the retrospective study as well.
Yeah.
In the prospective parts, gap in hallucination.
Yeah. I mean, that's always a problem.
Yeah.
Are you planning to compare this with some clinical perfusion data using contrast agent? Maybe is it feasible?
I'm not planning on doing this, no, because so the data set I'm now working with people that have data acquired in Oslo. They have a pretty large data set and they're just using arterial spin labeling. And this already, the data is pretty good. So, I mean, there are a lot of studies that compare DCE or DSE with ASL. So that's not the point I'm pursuing. But I want to make sure that just the quantification tool that is commonly used can be quicker, and we can train on less data.
I don't hear you. The recommendation.
I'm doing this right now, so instead of just, the question was why I don't use data augmentation. So normally, I told you the problem is that we have movements in the data, and I just wanted to see if we can get rid of some images and still get maps, but now I'm also doing augmentation, meaning I'm artificially producing movement, and this would be even better because then you don't, because right now if you would use this clinically, you wouldn't have to see which encoding steps have artifacts in them and then take them out. But yes, it would be more feasible to just take the data set in there that has movement in it, so I'm using augmentation for artificial movement right now. But there are no, it's pretty fresh, so there's no results yet.
Do you have contrast agent examples in this data?
So question was if I have contrast agent imaging examples. No, I did not. I'm just comparing the ASL images with generated ones, but as I said, there are tons of studies that compared these two methods. But I can I can show you how ASL images can look like. I mean, probably we'll see more about the glioma one, but here's two examples of what ASL can do. So on the left side you see, so on the top you see the structural image, and yeah, probably if you're an expert you can also already see the glioma in there, but if you look at the perfusion image generated with arterial spin labeling, no contrast agent needed, you can see pretty clear where the glioma, I'm not using this, you can see it anyway, where the glioma is. And also on the right side we have an example of Alzheimer's disease, and again on the top you can see the structural images, and if you just compare these two, you could not just by eye say that the right one is structurally different compared to the left one, but if you look at the perfusion images on the bottom, you can clearly see a big difference in the perfusion signal, especially where these areas are. Occipital-parietal area is where we see change in perfusion pretty early in AD, even if there are barely any symptoms. So you don't really, I mean, SNR is really challenging in ASL, but still perfusion signal can be pretty strong.
That's my.
Did you look into other CTC parameters? There are tons of perfusion, not tons of, but 6-7 different parameters. Did you compare also on those outputs?
Oh, sorry, I didn't get it.
In perfusion, there are a lot of CTC parameters.
Mm-hmm.
So you are looking at an output using one of those parameters, maybe, right now?
Two, yes. So I'm using CBF and ATT maps.
So So there are some other perfusion parameters. Do you think that would be feasible to look into those as well?
I mean, probably yes, because it learns CBF and ATT pretty strong. So I think also generating different parameters wouldn't be a big problem for it. But I have not tested it. I just use CBF and ATT. But also we're trying to, so with a new data set, we also want to see if we can see the exchange parameter. All right, and if there are no more questions, I think I can hand over to the next person. Thank you again.